Thanks to everyone for joining us today. We've got Dr. Yeoman with us today. Thanks so much for joining us. We really appreciate you taking your time out. A little bit of housekeeping before we start. Just remember that these Q&As do not take the place of a consultation with your own clinician. In these sessions, we're aiming to provide general medical information and not medical advice. And because of that, we'll generalise your question. And if you need help with a more detailed issue, please contact us on the helpline. As I've mentioned, I'll be recording the session here in Click Meeting, but just bear in mind that that's only recording the two screens of the doctor and myself. The chat section is not recorded, so we can put questions in there and answer in there, no problem. I'll get started on the questions that we've had sent in. If you've got any questions for us live, if you put them in the chat here, I'll pick them up from there. So first couple of questions today are about URSO. So we've got a patient who's diagnosed in April this year and awaiting their consultant appointment. Yep. Having only started taking URSO 250 milligrams this past 6 weeks, they've found it difficult. They're being sick after after eating and taking a pill, and it's not consistent. Ultimately, they need to get their URSO dose up to 2 tablets 3 times a day because of their weight, which is 110 kilograms. They've tried building it up, starting 1 a day, then 2. They're now at 5, but they're getting sickness and stomachache when they take it after a meal and with their other medications for high blood pressure. Is there a better routine to take the 6 a day? That's when they should be timed away from other pills, and if so, by how much time?
Yeah, a bit of a challenge, this one, isn't it? I think, so URSO is generally very well tolerated by the majority of people, but about 10 to 15% of people will get side effects from the medication. The commonest one is diarrhea, but that's not to say you can't get sickness as well. Lots of medications can cause gastric upset. So I think the person has already worked really hard at trying to sort of split the dose and escalate back up that way around. So yeah. In that sense, there's no other easy schedule. What I would say, though, is that there are several different brands of URSO which contain the same active drug, but they might have other constituents within the tablet or capsule that may or not be associated with different side effect profiles. And when the side effects are relatively generic, like tummy upset, then actually sometimes switching to a different brand of URSO would be my first recommendation. So if I was seeing this person in my clinic, the first thing I'd see is what brand of URSO they've been prescribed, and then look for a different one of that and see if they can tolerate a different one. Because sometimes it's not the URSO that's upsetting the stomach, but actually it can be some of the other constituents of the tablet or capsule which help with absorption into the body, etc. So go back to the GP or whoever's prescribed that medication and see, is there a different preparation you can try, because it is important that you're on the optimal dose of URSO, as this person clearly understands.
The other question about URSO was actually further down my list, but I moved it up, and it is about brands. So is there a recommended brand of URSO, one with least potential side effects? Picked their prescription up from the pharmacy recently, and they've got a mixed box, so they've got multiple different brands. It's not that they're sticking with one, or is there one that's recommended?
There isn't a recommended brand. I mean, I think, and that's partly because when URSO was first used to treat PBC, it was already being used off license. So URSO wasn't developed for use in PBC. It was originally developed to help shrink gallstones down. So many different generics have been utilized in this situation. So what I would say is that if whatever brand you're on, stick with that brand, because although the drug itself should be the same, the absorption, it can be slightly different between different brands, and so some people might get on better with one than another. It's not desirable really to have multiple different brands in the same box. It should be the same brand, and you should look to stick with the same brand. So I don't think there's any clear evidence that one brand of URSO is better than the other, but whatever you've been on before, if you're tolerating that and you've had a good response to that medication, it's probably best not to change that. There might be extenuating circumstances and the brand that you've been on before is suddenly no longer available, but that should come at the discretion of your prescribing doctor, rather than just having a different brand given to you willy-nilly. So it is best to stay within the same brand that you've been on before. But as I said, if you're having intolerance issues, then changing to a different brand is often a good way forward.
Great, that's great, thank you. We've got a patient diagnosed earlier this year during a routine health check. Ultrasound's normal, Fibroscan was 7.4, blood's been done next week and seeing consultants soon. They're finding themselves not looking forward to the festive period so much because of that and not being able to overindulge. Healthy weight, exercises regularly and eats healthy, and still drinks a little alcohol within the agreed limits. Any tips on how to balance the Christmas period would be appreciated.
So, I mean, far be it from a liver doctor to suggest people overindulge in anything, but certainly, you know, joking aside, this can be a real issue for people, isn't it? That transition to having a new condition for the first time and how to look after yourself. Look, I think, you know, a normal Fibroscan 7 is very reassuring. Obviously, we don't know what the liver blood tests are, but actually, if you've no evidence of background liver damage, there's no suggestion of any serious liver disease at this point in time. And I think life is a balance, isn't it? And it's important to try and enjoy life, because, you know, there's little point in living to 100 if life's absolute drudgery and misery. So I think what we would say is that if you want to have a wee drink over the Christmas period, as long as it's within reasonable limits, then that would be reasonable. Same with eating. If you've already got a healthy weight, then putting on an extra pound or so over Christmas isn't going to change anything. It's not going to suddenly make your PBC more difficult to manage or more complicated or more advanced over the longer term. So short-term changes in dietary intake are not likely to have long-term impacts. And reassuring for this person off the background of their Fibroscan, they've got a pretty healthy background liver there as a good sort of platform, if you like, which to sort of, you know, treat yourself from time to time. So it shouldn't be about, when we talk about dietary advice around alcohol and we talk about certain foodstuffs, it's about making sure that you haven't got a diet that's too rich in unsaturated fats and lots of ultra processed foods on the regular basis. Once in a while is fine, and Christmas is a one-off period of a year. So I think it's important not to become too negative and too over health focused, whilst keeping an eye on the broader picture of keeping a healthy weight and healthy alcohol consumption for your longer term health. But short term, a couple of drinks over the Christmas period is not likely to be detrimental for you, and it's important to get that balance right.
I like this question because I think a lot of people think about it, especially if they're newly diagnosed during the year. And I think it's good that it was asked, although I am disappointed myself that we're still in October and I've let a Christmas question in. That's that. I should have pushed that till next week when it was November and it's allowed.
Pre-Halloween, yeah, noted and duly judged.
Yes, I should be. Next question, is insomnia connected to PBC? I've spoken to others with PBC who say they also have issues with sleep.
Yeah, it's not a classically associated PBC symptom, but of course any chronic illness can be associated with fatigue, with insomnia rather. So other associated PBC symptoms, obviously itching being the most classical one, will clearly impact on sleepability, sometimes or sleep hygiene. Sometimes people find that worry about their condition can exacerbate insomnia. So it's important that those things are explored. Look at other habits around insomnia as well. So trying to avoid lots of backlit screens late into the evening, for example, that's been associated with insomnia. So it's not a classical PBC symptom, but any chronic illness can be associated with an increased likelihood of having sleeping difficulties, particularly if anxiety and worry is a feature of living with a chronic condition. But bear in mind that insomnia is relatively common in the general population as well. Mm-hmm. So thinking about a good sleep hygiene, there's lots of online resources to help you manage that. Try to avoid caffeine late in the day. Try to avoid eating too late into the day. Try to avoid, as I say, too much excess stimulation. For me, if I pick up a book, I'm asleep within 10 minutes because I want to do it. But certainly try to find other things like reading rather than looking at backlit TV or computer screens late in the evening can also be associated with better sleep hygiene. But if you still have an ongoing issue, then obviously we'd usually counsel people to have a conversation with your GP about that. But it's not a classical PBC symptom, but we do see it in people with any chronic illness.
That's great. Thank you. Next question. I've heard recommendations that coenzyme Q10 to help with energy. There are quite a few in the market. Any tips on ingredients to avoid?
So those supplements should just contain that compound. I think, the rationale for using it in somebody with PBC is that coenzyme Q can help boost energy levels by boosting ATP production. So ATP is the chemical that our body produces that drives all our energy. And what we find is that it's produced by your mitochondria. You'll all be familiar with that term in PBC. You have anti-mitochondrial antibodies, and that's what really probably drains the body's battery. So the mitochondria are the energies and the body's energy cells. And so, a supplement like that, which might increase ATP levels, can be associated with an improvement. There's not robust studies, if I'm honest, showing that there's a direct benefit, but there's no evidence that it's harmful for your liver. So as long as you're taking it in reasonable quantities and not popping them left, right, and center, that will also be very expensive for you, and there might be some adverse effects from that. So we don't think it's harmful. We're not quite certain in whom it will benefit. But I guess if you try something like that and you're struggling with fatigue, and we don't have good treatments for that, I totally understand why people will look for these over-the-counter or sort of supplemental therapies. If you find it benefits you, then by all means carry on. But there's no specific preparation that's been shown to be better than the other. But you can kind of see why there's a rationale for its use. But I guess response will tend to be very, very variable, because some people might not be lacking in that chemical. It's not something we can easily measure. And so if you're not lacking in that to begin with, it's not going to give you a significant impact. But if you find something that's, not toxic, makes you feel better, and nothing else we have in our armory is particularly effective for fatigue, then by all means it's entirely reasonable to try it.
That's great. Thank you. I've heard that coffee is good for the liver, but also that it can be difficult for the liver to metabolize. Any information welcome.
Yeah, so the caffeine in the liver is an interesting one. I think what we see is that from large-scale population studies, people who drink 3 or more cups of coffee in a day have a lower risk of advanced liver disease. Now, the theory behind that is that caffeine contains antioxidants, and antioxidants are chemicals that help your body mop up toxic chemicals. So from a PBC perspective or from a liver disease perspective, anything that damages the liver will produce oxidized chemicals that can be harmful to the liver. So something that goes around mopping that up can often be desirable. We don't know the precise mechanism by which coffee reduces liver disease risk. And we're not quite certain whether there's other behavioral elements of coffee drinkers that also will reduce the risk of liver disease. But there's a plausible biological link because of that. We know caffeine does have some antioxidant properties. In terms of the liver not being able to break it down, I think your liver's going to be pretty badly damaged, quite advanced liver disease before that becomes a material issue. And sort of certainly the threshold seems to be around that sort of 3 to 4 cups of coffee in a day, no more than that. And I think certainly caffeine is quite a stimulant, and that can have impacts on negative impacts on heart rate, blood pressure, insomnia, and other things like that. So it's important to not think that, even though some studies suggest there is a lower risk of liver disease in people who drink more coffee, that there will be a limit to which that caffeine will have an impact, and eventually you start to suffer sort of adverse effects. So keeping it about 3 cups a day is probably sensible. But as I say, we don't quite know the mechanism just yet.
Great. Is low blood pressure an issue with PBC?
It's not directly. No, there's lots. We talk about a lot of these Q&As about indirect effects that people might suffer from a condition. It's not there's no specific thing about PBC that should directly make you have a low blood pressure. But low blood pressure can occur from other autoimmune diseases. Addison's disease is probably the most common of those. So if you've got an issue with unexplained low blood pressure, then it would be worthwhile having that excluded by your GP or your doctor to make sure you don't have concurrent Addison's disease, which is a different type of autoimmune disorder.
Great, thank you. There's a question later about autoimmunes. Actually, I might give it to you now because I thought it was quite an interesting one. Wait till I find it. How do you determine what's primary and secondary in autoimmunes? So if someone does have 2, is it the diagnosis time, or is there a Yeah,
it's an important thing for you living with 1 or more autoimmune conditions. I don't think we ever really talk about one being primary or secondary. So when we talk about the reason we call PBC primary biliary cholangitis is because it's a primary condition that's intrinsic. You can't control it. It's not secondary to something else. And that's because there are certain drugs that can affect the biliary system, for example, and cause biliary inflammation. So that would be a secondary biliary inflammation. So that's how, when we talk about the primary versus secondary, I think from a clinical standpoint, it can sometimes be helpful to consider which of the conditions are affecting you the most. That doesn't mean one is primary and one is secondary. They are both occurring at the same time. And if you have autoimmune diseases, they are both primary by definition in a medical parlance. So It's more really about thinking about which of the manifestations of your autoimmune conditions are affecting you the most and making sure those are appropriately managed. So if it's itching from your PBC, or it might be you have PBC and lupus, and actually your PBC is not affecting your liver in a major way. You haven't got itching, but your lupus is very active, and therefore you need to think about making sure that that is adequately treated.
Great, thank you. We have a question about diagnosis and about liver biopsy. I know that we can't give any specific advice, but I'll read you the question and then we can generalize it for the answer. So a patient who's been treated for PBC for the past 2 years, however, they're negative for the anti-mitochondrial antibody.
Yeah.
They've refused a liver biopsy as they have bleeding issues and they're concerned about safety having that kind of procedure.
Yeah.
They're currently taking Urzo and their numbers have decreased but are still out of range. Concern is that the doctor has told them that because they won't have a biopsy to formally confirm diagnosis, this makes them ineligible for second-line treatment.
Yeah.
Any experience of treating patients in this situation and any way around the biopsy?
Yeah, this is a tricky conundrum because we know the majority of people who have PBC will have AMA measurable in their blood, but a small proportion won't have AMA measurable. And it's usually that the diagnosis of PBC then is usually based on performing a liver biopsy and looking for compatible features under the microscope. If that's not possible, then you have to get more creative in terms of trying to make sure you've got an accurate diagnosis. Mm-hmm. Now, it depends on how much the ALP is improved, because sometimes we will look at somebody who has a negative AMA, but whose ALP is very, very high. We'll often look at what the IgM is doing. Immunoglobulin M is a protein, an antibody that is secreted in higher concentrations in people with PBC. And sometimes, even without a biopsy, we've given people a treatment trial of Urso to see if that will improve things. And if that improves the liver tests dramatically, then there's a reasonable assumption, even without a biopsy, that that person has PBC. And that might, depending on which part of the world you live in, that might make you eligible for second-line therapies. There is also an extended panel of autoantibodies. So we all talk about AMA, but actually there are PBC-specific ANA or anti-nuclear antibodies that can be measured. And some other labs can do even more extended antibody assays again. So it would be worthwhile asking the medical team if there are other antibody. They might have already done those things, but if there is an extended antibody profile, that might be helpful to nail down a diagnosis of PBC. And if that's present, that can give you a firm diagnosis without recourse to a liver biopsy.
That's great, thank you. I'm just going to move over to one of the questions we've got in the room here. Can you continue taking, my pronunciation, atorvastatin when you're going to start bezafibrate?
Yeah, so some people do take atorvastatin and bezafibrate. They're both drugs originally used to bring cholesterol down, but they work in different ways. The caution you have to exercise when using atorvastatin and bezafibrate is there is a higher incidence of muscle injury. So one of the commonest side effects of bezafibrate and one of the limiting steps with use of bezafibrate is muscle pain or myositis. If you're taking both, then there is a higher incidence of myositis. That's not to say that they can't be used in combination, but you have to be a little bit more cautious. And I think you have to make certain that the person's aware of that risk. And if they get any muscle soreness or discomfort around their joints or in their muscles themselves, to report that straight away and get a blood test check to see if there's any evidence of myositis. So it's something that should definitely be done eyes wide open from the patient's perspective, but also from the clinician's perspective. And I have added in bezafibrate to people who are on long-term atorvastatin, but I will counsel people that there's a higher risk of side effects, which might mean then they then to discontinue the bezafibrate.
That's great, thank you. If a PBC patient has a Fibroscan score of greater than 10, what treatment or advice would they be given?
Okay, so the first thing is, so assessment for the severity of PBC is based on a number of different features. So we look at the degree of ALP rise, and we look at the degree of liver damage, and obviously we look at the severity of symptoms. Because although severity of symptoms doesn't always correlate with severity of disease, that still matters to you hugely. So if we think back to the Fibroscan, a Fibroscan of 10 in PBC is not cirrhosis, but it is suggestive of a stiffer liver than we would like to see. What's difficult to say is that we know that in early well, not in early stages, but when people are first diagnosed with PBC and the ALP is quite high, the Fibroscan scores can be higher. And then after a year of urso or any other therapy that brings the ALP down, we do see the Fibroscans tend to come down again. So that Fibroscan of 10, even if that is all scar tissue, even if it's after a good period of time on treatment with a good biochemical response, i.e. reduction in the ALP below the threshold, that is still some way away from cirrhosis. So in terms of what would that mean for your treatment? Well, it wouldn't mean you need surveillance for complications of cirrhosis because that person doesn't have cirrhosis. What it would mean, though, is if the ALP is above the threshold of 1.67 times the upper limit of normal, then it would be really important to bring that down, because if your liver Fibroscan is elevated, you would be at higher risk of future progression of liver damage compared to somebody who has a completely normal Fibroscan.
Okay.
It doesn't mean to say that it's inevitable, so don't be alarmed. And we see some people, as I say, in the early stages when they just started treatment, Fibroscan starts off at 10, you treat them for a year or so, and it comes down to 6 or 7, which is in the normal range again. Mm-hmm. So what I would say is it's sort of mid-range, low to mid-range, no immediate cause for alarm, but what it focuses in, should be in the clinician's mind, is you want to make certain that it's coming down if therapy's only recently been started, and you absolutely want to be certain that people are on all suitable available therapies if the ALP hasn't responded well to the initial first or second line treatment.
That's great, thank you. A question that's just similar to what we're talking there about the year time and checking within normal range. Once a patient's been taking Urso for a year, what would be a good indicator that you've responded well? If your LFTs are out of the normal range, would this mean the medication isn't working, or will your LFTs always be a bit above normal?
So I think we talk about this response criteria of 1.67 times the upper limit normal for ALT. There are other response criteria, several response criteria in PBC. We've sort of latched onto this 1.67 times 1 because that's the threshold that was used in the obeticholic acid trials and has now been used in the new elafibranor and seladelpar trials. So it seems to become the de facto gold standard response criteria. But there are others available, and some of the others do incorporate other liver enzymes, ALT, for example, and some of them also incorporate bilirubin into their response criteria. What we're looking to see is that people's liver blood tests, usually ALP, fall below that threshold of 1.67 times the upper limit of normal, because we know that the progression of liver disease is much, much lower when you are below that threshold. However, these things are not binary, they're not absolutes. So it doesn't mean to say if your ALP is above that threshold, you will definitely progress. It also doesn't mean that if you're below that threshold that you won't progress. It just means you have a significantly lower risk. Now, Mo, you'll know this, and people who are regular listeners to these Q&As will know that we're starting to talk about should normal be the new normal in PBC.
Yep.
We haven't yet got the robust clinical data to say we should be doing that yet. But I think there's many of us in the community that think if we can reasonably get somebody's ALP to normal, that is going to be associated with a much lower risk again. And so normalization will take your risk of progression down from being moderately high, if you haven't hit that threshold, to low. But actually normalization will almost certainly make it lower again. So it's about maximizing or minimizing the risk of further liver disease progression over time. So at the moment, we still use this threshold, but the lower the ALP goes, the better. So should we expect the ALP to be normal? Well, no, the ALP is abnormal because the condition is still there and there's still some consequences of that condition. You might logically think, well, why didn't we go for normal from the beginning? I think part of that was because for a long time we only had one drug that wasn't, initially thought to be very effective, and over a long period of time, we got evidence that Urso was effective, and so the other new therapies are coming online, but they are very, very expensive, and it's about how we bring those in to make sure that we treat people cost effectively for the whole of society. And then the other aspect, of course, is that some people with PBC will never develop their significant liver fibrosis. People often think it's inevitable because I have a liver condition that my liver will only get more scarred. Some people just don't ever develop significant scar tissue. And so it's trying to balance out all those different things. So if the ALP is elevated, yes, there's still some degree of autoimmune activity, but we know if it's below that threshold, that the risk of you developing severe liver damage is far, far less. But there will be circumstances where your doctor will be saying, look, we would like to get this lower still and within the normal range. And that's usually in people who've had a very high ALP when they first presented with their PBC, or they've already got significant background damage on a Fibroscan or a liver biopsy, because for those people, it becomes even more important to get that ALP down to normal.
Yeah. We were talking a bit about some of the second line treatments there. There's a question in the chat here. Patient in the UK who's on UCA and obviously just been taken off the market in the US and in Europe. It's working well for them, but they worry if it's taken off the market here, what would happen in terms of other second line treatments if their mechanisms work differently to UCA? Could we talk a wee bit about the two other second line and the way they work compared to UCA?
Yes, so I think seladelpar and elafibranor work on pathways very similar to what bezafibrate does. So think of these elafibranor and seladelpar as being much more specific and effective versions of bezafibrate. Probably a lower side effect profile and more efficacious. Although there's no head-to-head studies, in the individual studies, there seems to be a significant improvement or greater improvement in both ALP and the proportion of patients who are normalizing ALP. What's interesting about these two new drugs is for the first time, those trials actually reported not just on a reduction in ALP below a threshold, but normalization. And there's around 50-70% in elafibranor, around 20-odd% in seladelpar. So we're starting to see these drugs now being tested to try and aim for normalization of the ALP. Obeticholic acid works on something called FXR, so they work in very, very different ways. So theoretically, they could be complementary, which is why we are very concerned in the clinical field that these drugs are potentially being lost in some jurisdictions and may become lost to us in the UK as well, because there will be people, no matter how good these new drugs are, none of them are perfect. They don't give 100% response rate, and there will be people who will improve their ALP on, say, urso and elafibranor or seladelpar, but don't get to within that threshold. And we do need to get them under that threshold, or we do need to get them normal. So having as many different classes or types of drugs to treat PBC, we think is still important for us to be able to use for specific individuals. So the drugs do work in different ways. In terms of if you're already on obeticholic acid and you're within the UK, it hasn't been withdrawn in the UK, and we haven't been given notification that it will be withdrawn within the UK, although there is obviously that fear given what the regulators have said in US and Europe. I think a really important thing for people to understand, though, is that it's not been withdrawn because people think it's dangerous. The recommendation for withdrawal has been based on no long-term evidence of benefit, but that's largely because we haven't been using the drug for long enough. So there's a bit of a discrepancy, really. The regulators have a different view on this compared to us in the clinical sphere. There's very few people, I think, in the clinical sphere think we should be losing access to this medication, because we know it works well for a proportion of people. And we know that particular mechanism of FXR agonism might actually deliver a better response than the PPAR aspect of elafibranor and seladelpar. So it's good to have lots of different tools in the toolbox. So at the moment in the UK, it is still available. The company is still making it available. And at the moment, the MRHA, which is our regulatory body for medicines in the UK, is evaluating the evidence to see whether it will remain on the market in the UK. We haven't been given an indication of exactly when that will be. The decision seems to be kicked into the long grass every sort of few months or so, doesn't it, Mo? And I know you and the PBC Foundation are all over this. So as soon as anybody knows, you will know through the foundation.
Well, we'll keep patients posted.
So at the moment, we're not recommending people switch, because if you're tolerating that well, we will. If it does get withdrawn, will the company make it compassionately available? I think that's fairly unlikely if it's been withdrawn worldwide, because in some cases, sometimes a medication has not been recommended by the regulators, but the company is continuing to make it available for people as a compassionate use. But what will probably happen is if people don't, if it does get withdrawn and we no longer can issue it to people, then it would necessitate a switch to either elafibranor or seladelpar, and then with close monitoring to make sure that the same responsiveness is being achieved. Now, what is difficult to know is, because we don't have the data, is what proportion of people who have responded well to OCA will similarly respond to elafibranor or seladelpar. That data is simply not available. If you look at the crude studies, based on the people treated going into the study, then the proportion of people who reduce their ALP below the threshold and the proportion who normalize does seem to get better the newer these agents become. So the newer drugs seem to be a little bit more effective, but it's really important to remember that there are often different patient characteristics in those studies, and so you can't always compare one historic study from 10 years ago to a study now, because there might be slightly different patient characteristics. There might be slightly higher baseline ALPs, for example, and there might be other associated characteristics which might alter that individual person's treatment response. So those studies are not going to be done by the pharmacological companies. We'll only get that data when enough people in the general population have been treated with both obeticholic acid, elafibranor, and seladelpar, and then we can accrue that information to say, well, actually, if those come off OCA and they go on to one of these other two new agents, we will then be able to see it. Well, actually, we get a maintenance of response. But we don't know that yet for certain. So there will be that little bit of element of the unknown, but they do seem to be very, very effective therapies. And crucially, I think, compared to URSO particularly, all these new drugs work a lot quicker. So the good news from that point of view is that actually you don't have to be waiting 6 and 12 months to work out whether that new drug is working for you. You've often got a signal quite early on, and within 3 months or so, we're seeing a significant improvement in those who are responding. So you're not waiting as long to find out if you do have to make that switch. So I understand it is an uncertain time for people. At the moment, if you're in the UK, it is still available. And at the moment, I've not been recommending a switch to any of my patients who are managing it well. But what I am saying is that if you're struggling with itch on obeticholic acid, even if you've had good biochemical response, then, and other standard itch therapies are not working for you, then switching to these other drugs might be a useful thing to do now, because these other drugs certainly don't increase your itch like obeticholic acid can, and there's a bit of a signal that it does marginally improve itch for some people.
That's great. And just to mention as well, we have been doing some extra sessions for our US patients around the withdrawal of OCA, and our next one is with Dr. Robert Gish on Monday the 3rd of November. That's on the all our US patients should have received that information, but if not, just reach out to us and we'll get that for you.
Yeah, one not to miss that would be brilliant.
We've done a few specific ones just really like that question. If that was a US patient and it is being withdrawn, what happens now and what's the best way forward? We touched on, when we're talking about trials there's the question about trials. If you participate in a trial and you're given a drug which improves your life and health, once the trial stops, can you still access the drug, or do you have to wait for it to be formally approved? That changes drug to drug, and so it should be made clear when you consent to the trial whether the drug will be made available to you so if it hasn't yet been licensed and the studies have shown it's effective, then what most companies should do, but they don't always, is they should make it available as a compassionate use drug to you to carry on until licensing or otherwise. However, that isn't always the case, but it should be made clear to you at the time of consent, because it's a really important issue, isn't it? Because there've been some cancer therapies, haven't they, which have worked really, really well for some individuals, but because it didn't work for enough people, have not been given a license, and then people have been left in limbo. And at the moment, the regulatory bodies do allow the companies to not automatically provide compassionate access. I would fundamentally disagree with that. I think if somebody is willing to take that risk, because there's always an element of risk when you go onto a trial medication, if somebody's willing to take that risk, then I think the company should have a responsibility to provide that, but it's not invariable. But if you go into trial, ask when you go for a trial visit, will this be available if it benefits me, because they should have made that clear at the outset. At the time of consent. That's good. That's good to know. And that's when the questions should be asked. That's great. I'm just going to pop back into the chat in the room here. When we were talking about OCA earlier, the patients asked again, I heard earlier about sleep issues. I have insomnia. Is this a known side effect of OCA?
It's not something I've seen with OCA, no. So I think with insomnia, as I said, I tend to look for associated factors. So it's looking at good sleep hygiene, making sure you're avoiding other external stimulus late into the evening, and it's not something that I've seen with OCA, if I'm honest.
Great, thank you. Can you have gallbladder issues resulting in can having gallbladder issues result in having PBC? Is there a connection?
It's kind of more the other way around, isn't it? In that we know that having PBC makes you more likely to have gallstones, and so that having said that, not everybody who has PBC will have gallstones, and not everybody who has PBC and gallstones will suffer problems from them. So the general advice remains the same, is that if you have gallstones and they're not causing you any symptoms, you leave the gallbladder well alone. But if you do have gallstones, which you are more likely to have if you have PBC compared to the general population, and you're symptomatic, then the gallbladder removal would be advisable. But there's no evidence that having gallstones drives your PBC in the first place.
Is there a link between previous glandular fever and PBC?
Yes. So I think the link is not clear in terms of what the degree of risk is, but I think we certainly know, and there's much better data around autoimmune hepatitis, for example. But viruses and other external triggers, it can be a drug, it can be a vaccination, can trigger that autoreactivity. So autoimmune conditions is where your immune system misrecognizes you as you, and it thinks, instead of thinking, oh, that's Mo, it'll say, oh, I think that's a foreign body, I think it's a virus, a bacteria. So it'll go on attack mode. So we consider autoimmune diseases as people who have autoimmune diseases have a genetic predisposition, and then something triggers that. Now, sometimes it could be random. There isn't an obvious trigger in many people, but for some people, they have had a new medication. For some people, they have had a vaccination, or they've had a virus, and actually that virus has triggered these things. And there is, established plausible, link between glandular fever and other viruses and triggering autoimmunity in people who already have susceptibility. So yeah, absolutely, it can be a triggering event for some.
Okay, just going to pop a little message in the chat there, but if you have got any other questions, just let me know. What daily dose of vitamin D is recommended in patients with PBC?
Good question. So there's no established fixed dose, because I think PBC affects people at, well, first of all, different ethnicities, different ages, different genders, and all those things come into play in terms of the decision making of whether you might need supplemental vitamin D. So go back a little bit. NICE, which is the regulatory body in the UK about medicines, recommends that all of us in the UK should be taking vitamin D during winter. Okay, usually at around 400 international units, which is about 10 micrograms. So we should all be doing that. Most of us don't, but we should all be doing that. If you are darker skinned, then many people will be recommended to be taking it all year round. If you live in a country like the UK where we never see sunlight, because vitamin D is produced through exposure to sunlight. So roughly speaking, it's a good idea in winter to supplement your vitamin D, unless you live in an extremely warm country. I'm talking about the UK here. If you have significantly advanced liver disease, and most of the data comes from people with cirrhosis, not just PBC specifically, then the dose is recommended to be around 800 international units a day, which is around 20 micrograms a day. Okay, so if you're on calcium vitamin D3, that's 2 tablets a day. So a higher dose if you've got significantly advanced liver disease. So between 400 and 800 international units a day, what we would be normally recommending if you have PBC. If you've got PBC and you're very young though, and you've got you undertake weight-bearing exercise, you're physically active, you've got good calcium intake in your diet, it's not mandatory for everybody if you haven't got significantly underlying liver disease. So ask your doctor whether you should be on vitamin D supplementation, but certainly think about getting some supplements over the winter months. Some people find it does help with their general mood. Some people find it minimizes the seasonal affective disorder that we can get in in more northern climes because we don't see enough sunlight. And also vitamin D is an immune system booster. So we found, for example, that during COVID, people who had low vitamin D levels were much more likely to have severe COVID. So vitamin D is important for good functioning immune systems, so to help ward off infections. So it would be a reasonable thing to do. But in terms of outside of winter months, do you need vitamin D on a consistent basis for PBC? Very much depends on your personal circumstances and whether you have advanced liver disease or not. And then a recommendation can be made by your doctor.
Great. And just as a follow-up to that, we've got another question about vitamin D. Can too much vitamin D cause hypercalcemia?
It can, yeah, absolutely. So, but generally at the doses we've just talked about, at 400 international unit, 800, which is 10 or 20 micrograms a day, that is exceptionally unlikely to be the case. Okay, so generally speaking, if you're going to get vitamin D causing hypercalcemia, which is pretty unpleasant, you can get lots of bone pain, constipation, abdominal discomfort. It can even make you very confused and disorientated. You're probably looking at doses of 4,000 international units a day. So, 5 times the cirrhosis treatment dose. So you've got to be taking a heck of a lot of it. But it's like anything, too much of a good thing can be a bad thing. And so if you're deficient in vitamin D, supplementation is required. But if you have too much of it, that can be detrimental as well. But you do have to take quite a lot to get hypercalcemia.
Great. Just keeping a wee eye there to see if there are any more questions coming in. Can you explain about cholesterol, please? Which readings should we be looking at to see if we need to go on a statin?
Good question again. So again, this is highly individualized. So we don't tend to do a lot of statin initiations in hepatology. There's no specific liver indication for statins at this point in time. However, we come across this quite a lot. We get asked lots by GPs. I want to use a statin. Can I use a statin because they've got liver disease and risks of or concerns over the statin affecting their liver? First thing to say, statins have a very, very low risk of causing significant liver injury, even though everybody's very sort of twitched about it. So when it comes to who needs a statin, there's something called a Q-risk score, and your GP will usually calculate that, and GPs are usually quite hot on Q-risk score. It's something that's been promoted for a number of years because it promotes good cardiovascular health, reduces your risk of cardiovascular events in your heart and in your brain, so stroke and heart attacks. So your Q-risk score, if it's above 10%, you'll normally be recommended to have a statin. But your Q-risk, it looks at a number of things: your age, your gender, your family history, your blood pressure, smoking history, and other associated conditions. So all that information gets chucked into the calculator, calculates your risk score, and it just says if your Q-risk score is above 10%, then that would justify the use of a statin. And so that's usually that's the decision-making process in the UK. I don't know what they use in other parts of the world. I suspect it's probably pretty similar. But that's so you do an individual patient risk assessment, looking at all the associated features that person has and their individual risk, and then a recommendation is made based on the Q-risk score.
Great, thank you. Just got a question in the room here. Can the doctor explain anti-GP210?
Yeah, GP210. So yeah, that's earlier on. I talked about this extended panel of autoantibodies.
Yeah.
So this is one of those more extended panels. It's much more specific antibody for PBC. So again, it's one of the things we would look to do if we really try to focus in on whether somebody has PBC. And so yeah, it's part of the extended panel.
Great, thank you. Why are symptoms generally worse, progression worse, if you're diagnosed at an earlier age?
So this is true across lots of autoimmune diseases, is that the younger it comes out in you, the more active it seems to be. Now, therefore, there's a couple of reasons why you might have more progression. So the younger you're diagnosed, you've got more life years to accrue complication, because say liver damage, if it is going to occur for that individual, occurs at a fixed rate. It's different between individuals, but even if you make an assumption that it occurs at a fixed rate, if it's going to happen, if you're diagnosed in your 70s and your minimum life expectancy is another 10 to 15 years, then you're probably never going to live long enough for that to materially affect your liver. Whereas if you're diagnosed at 35, that's a very different equation. So some of it is due to the longevity aspect. The earlier you diagnose, the more life you're hopefully going to live with that condition. But also there is definitely something about autoimmune diseases that present at an earlier age. There's probably something different and pathophysiologically in those individuals. So we tend to think of autoimmune diseases as being this one entity. So autoimmune hepatitis is not one entity. It's many different episodes of dysregulation of the immune system that result in a common endpoint. And I'm sure there'll be different pathways involved in different individuals with PBC as well, which is why some drugs or some classes of drug will work well for some people and not for others. So, exactly what triggers that end damage to their liver can be different between individuals. And so in younger people, presumably their genetic makeup means they have a slightly different form of immune dysregulation. So once it's triggered, it's much more active and florid. And we certainly see that in PBC. The people we diagnose under the age of 40 particularly tend to have much higher ALPs and a much higher symptom burden. That's not invariable, of course. We do sometimes see younger people diagnosed and it's relatively mild, but on average, we will tend to see much more active disease, for want of a better word, when you're younger, probably because it's a more active form of the condition.
Mm-hmm. There's a question from earlier in the chat, and I think it's a really one to go. I'm just aware of the time as well, but I think it's a really good one to go back to based on what we were just talking about there. So, what do you make of the Nobel Prize for medical research on finding a cure for autoimmune diseases, among other things?
I think it's anything that shines a light on autoimmunity is hugely positive. I think there's such a huge array of autoimmune diseases, some of which have very effective treatments, some of which very few treatments. You look at PSC, for example, there's still no treatment for PSC at all.
Yeah.
And the treatment landscape for PBC until very, very recently was very, very limited. So anything that shines a spotlight on that will also, because what that does is, first of all, that will only be awarded because we've moved forward significantly in our understanding.
Yeah.
What that work does, it allows for other work to be developed, and other researchers will come in and go, oh, I see that, and they'll build on that, or they will learn from those researchers' work and develop new methods of understanding how autoimmunity behaves in different conditions, but also crucially try to develop new therapies. And also a Nobel Prize is very prestigious and it attracts a lot of attention. So it will resonate with funders, and it will mean that it does tend to generate more interest from funding bodies to drive more autoimmune research. So it's hugely positive for the autoimmune field in general, but we are still a long way off cures for these conditions. And it's important to remember that autoimmunity, whilst a genetic tendency, it can manifest very differently in different people. And so, both in terms of severity and the different organs that are affected and the likelihood of response to those treatments. So we're still some way off, but there's little doubt it's a huge boost to the field.
Do you think what we're touching on there as well about the change in the landscape for PBC treatments as well? I don't know if I'll see it. Will I see it at ASLD next week?
I won't be at ASLD, unfortunately, but
Robert and I are heading off to Washington next week for the liver meeting in the US, and this will only be my third time that I've been at such a big meeting. But even since those last couple of years, the change in how many sessions there are about PBC and seeing the research and what's ongoing, it's amazing to see the work that's going there. So Robert and I go there to make sure that the patient voice is heard loud and clear, and amongst that. So we'll give a wee report on how we get on the week following that. So thank you very much for taking time to join us today, Dr. Yeoman. We really appreciate it. Thanks to everyone in the room as well. And our next session is 2 p.m, back to 2 p.m. next week on Thursday.
Yeah, lovely.
Okay,
Good to see you all.
See you later. Bye.